All right, everyone, it's 9 in the morning, so let's go ahead and get started because this is have so much information to share today. I just want to welcome everyone to today's edition of VLU Empower Webinar Series. My name is Dr. Lina Vargas, and it is my pleasure to moderate today's discussion on order matters, decoding laser and sclerotherapy combinations. On behalf of Venous and Lymphatic University, I want to thank you all for being here. We have participants and we have guests from multiple countries, and we're so excited to have you all join us today. I am personally very excited about today's topic because it's one that I know all of us face on our daily practice when we're treating spider veins and reticular veins. We really haven't figured it out completely, and we're always worrying about getting those ideal results while minimizing complications. And so, obviously there's sclerotherapy and there's laser, but I love the combination treatments. And in reality, we don't have that much sound data that compare the two kind of approaches that we have. And so this is not about debating who's right and who's wrong, and we should all be doing exactly this. But we have amazing speakers all from Brazil, which I love, to share kind of the rationale behind their specific approach. And, they're going to share with us the science that's there, the research that's been done, and obviously their personal experience. So I'm very excited about this, and I look forward to everyone helping us, participate in this conversation and just having a meaningful discussion. Please make sure that you're putting the questions on the chat or that you're sharing them with us. So Nara, I would like to start with you. So Nara is gonna tell us about CLaCS, so laser before sclero, and I'm dying to hear, about your experience and for you to share your data with us. Go ahead.
Thank you so much. It's an honor being here. It's a good pleasure. And I will share my screen. Okay. It's okay. Are you seeing my screen?
Yeah, I can see it. We can see it perfectly. Thank you.
So it's a good pleasure being here again and to talk about an issue that I love. Today I will talk about what's the real place for CLaCS, and I am Master in Health Science from Santa Casa of São Paulo University. I'm a university professor here in University at Rio Grande do Norte, where I live in Natal, Brazil. And I'm the coordinator of the Pigmentation guidelines of Brazilian Society that we did last year. So CLaCS is more than laser with sclerotherapy. CLaCS combines previous photo documentation followed by proper diagnostic tool with duplex ultrasound, with augmented reality, and we use the skin cooling to prevent epidermal damage and reduce pain, followed by the laser and sclerotherapy. It's first described by Professor Kazu in 1999, and I intentionally started with this slide to show that the technique has evolved and no longer only involves the use of a single type of sclerosant agent. Now we can use more type of sclerosants. And before we start, let's remember what the ESVS guidelines saying about the treatment of varicose veins. So to treat telangiectasias, it's important to have adequate knowledge about the venous system when the purpose is cosmetic. According to the recommendation number 40, sclerotherapy is recommended as the first choice treatment for reticular veins, but for telangiectasias, it should be only considered. According to the SVS, the adverse effects for sclerotherapy are mild. The most frequent are hyperpigmentation, matting, and scar of the injection site. I disagree a little about being mild when we are talking about C1 patients, especially when aesthetic results are needed. The ESVS guidelines bring us that transcutaneous laser should be used now. And Parla and Coles concluded that sclerotherapy and laser may be used in combination for optimal management at telangiectasias of lower extremity. So now we have the hybrid techniques, and the SVS guidelines bring us this new concept. Recent technical modifications have been reported to substantially improve the effectiveness of the transdermal laser. And the objective of hybrid techniques is to achieve effective through the synergy between laser and sclerotherapy. So laser therapy relies on selective photothermolysis, whereas sclerotherapy functions through chemical endothelial destruction. And the synergy overcomes the limitations of monotherapy. As we can see here, the CLaCS technique is mentioned at the SVS guidelines as a new treatment option of reticular veins and telangiectasias. But we Brazilian vascular surgeons know that the treatment is not is more than promising, you know. The mentioned article in the guideline was this one, and this guideline brings us the definition of CLaCS that consists of the association of cryo-laser with cryo-sclerotherapy guided by augmented reality, and that CLaCS is a method, is not only a simple laser plus sclerotherapy, because CLaCS involves previous photo documentation, ultrasound detection of feeder veins with augmented reality, simultaneous cryo-laser with augmented reality, and the simultaneous sclerotherapy guided by augmented reality. This video I did in 2013 when I started practicing the technique more than 10 years ago. And here I show the simultaneous cryo-laser treatment guided by augmented reality with the cryo-sclerotherapy. The photo documentation, the detailed photo documentation should be mandatory in superficial vein treatment. Pre-treatment photographic documentation is important because most patients tend to underestimate their own improvement with time. The visualization and treatment of feeder veins are key to the procedure and optimal resolution on telangiectasias treatment on preventive recurrences too. So we have to treat in the root, not the symptom. And the CLaCS technique follows the principle, first do not harm. So the dextrosis 75% was the first sclerosant agent that was used to do the CLaCS technique. And was originally described like this by Professor Kazu. Nevertheless, this medication is not available in Europe and the US. So recently, a study published in 2023 demonstrated another sclerosing agent option using the combination of dextrosis and polidocanol 2. In this article, the object was to establish if there is a difference in results and complications by varying the sclerosant agent by keeping the same in the pulse laser and laser and with the same parameters. Was included 55 patients. The group 1 was laser plus dextrosis, and the group 2 was the laser with the combination of polidocanol and dextrosis. The results were evaluated 30 days after, and they concluded that the treatment with CLaCS using dextrosin or with polidocanol is safe and effective procedure and can be used with similar results. In this July, this meta-analysis was accepted for publication in JVS, and this meta-analysis compare the incidence of adverse effects between CLaCS and isolated sclerotherapy for lower limbs, telangiectasias, and reticular veins. They used the PubMed, Embase, and Cochrane to do this search, and the primary outcomes were metting, microthrombi formation, and hyperpigmentation. They included these studies, and here we have the study of Dr. Rodriguez and Dr. Fonseca, and included 6 studies, but only 3 was RCTs. It was found significantly lower rates of metting, microthrombi formation, and ecchymosis. So when we talk about laser parameters, there are really regulations that work, and knowing them could really help us in better delivery of results. Here we have a table with the parameters that we have to use to different lesions. But it's really necessary to change these parameters. So CLaCS technique nos permit that it's not necessary to change all the time the parameters. Here we have a lesion, and if you have to change the parameters, we have to use this what is described in here. But I used fixed parameters, and was the result after 1 month and after only 1 section with laser and dextrosis. So why to change the parameters? Because think that we are in a race car in Interlagos race, and every straight or curve you had to change the shock absorbed, it would be unfeasible to complete the lap. So therefore, when we fix laser parameters in our machine, we optimize time, and this is what CLaCS provide us. To end, I'll show some cases of mine. Here I use fixed parameters and I use polydocanol. My only cases are the result is with 1 section and 30 days after. Here I use laser and polydocanol too. Here I use fixed parameters and only dextrosis, only 1 section after 30 days. Here I use only dextrosis 2, laser and dextrosis. And here I use laser and polydocanol. Here I use laser and dextrosis. So to take home message is do not use laser as monotherapy for varicose veins in the limbs. The combination laser with sclerotherapies allows parameters to be fixed. Lower fluency for high Fitzpatrick and tanned skin. The only contraindication for laser treatment is tanning skin with erythema. So 2 or 3 sections with a minimum intervals of 30 days is necessary. And the best technique for the treatment of varicose veins is the one that gives you more confidence in achieving your respective results and the results of your patients with the lowest complications. Thank you so much. And sorry, I
No,
passed a
no, that was
little.
Nara, that was absolutely amazing. Thank you so much for sharing that wonderful presentation. I love that you showcase how, all of you guys are experts, and again, just so happy to have you all here. So I want you to kind of like literally like almost like take us as if we were like watching over your shoulder doing this. So because it's we understand the benefits of doing the laser with cryo followed with sclerotherapy, but when you just walk me through this, so let's say we have a typical lateral reticular vein on the thigh that's feeding a cluster of small telangiectasias on the thigh. Are you lasering just the reticular? Are you lasering reticulars and telangiectasias? Walk me through that just for us who are not doing this on a routine basis. I think you're muted, Nara. Nara, can you hear me? I can hear you. Well, in the meantime, let's just continue, and then Nara, I'll get back to you. Is that okay?
Lina, I see a lot Nara that is trying to
We're
get
fine with
the
listening.
micro on and off.
Yeah.
Yes.
So yeah, so let's just move forward with the next presentation while we see if maybe if Nara can maybe rejoin, maybe disconnect and come back.
Okay.
So yeah, so for the sake, Nara, is that okay? Can you try to see if maybe you can sign off and sign on again, or maybe reset something?
Now are you reading me?
Oh yeah, we can.
Yes.
Okay, beautiful. Thank you. Awesome.
Sorry for that.
No, it's okay.
It was my phone that connected with the computer.
Oh, gotcha.
So I use the laser to treat the reticular veins and the telangiectasias, and I
Okay.
use the same parameter for the reticular and the
Doesn't
telangiectasias.
matter size, color, depth, you stick with.
Yes,
And I saw
because
that you do like 50 to 70 joules, is that right?
yes, I use most of time the 70 power, but when it's painful, I use
Lower
50.
down. Mm-hmm.
And I changed the sclerosant.
Okay.
So the sclerosant is what I changed. I use polydoconol when it's necessary, and I use dextrose when I need a mild sclerosing agent. Because in with this, I can optimize the time, and the results are good too.
Yeah, because that's, I think, one of the main issues is the time constraints, right? And so after you've done laser, then do you immediately, so let's say you're treating someone who has multiple areas or has, extensive, are you breaking it up in different sessions, or let's say that you have different clusters throughout. Are you doing all of your laser and then coming back to your sclero, or are you focusing on one area lasering and then immediately doing your sclero before you move on to another area?
It's an excellent question too. I do the laser, and after immediately I do the sclerosant. I pass 2 or 3 times of the laser. In minimal 2 times the laser I pass, and in the most of the time I pass 3 times. And after I do the sclerotherapy immediately, and
Okay.
I try to treat the patient the most of the all the patient have, because as to optimize visits in my office too.
Okay, perfect. Thank you so much. That was really helpful. All right, well, I have a ton more questions for you, but we're going to move forward and then we'll come back to discussion with everyone. So next, I want to introduce Dr. Marcos Fonseca. He is a candidate at the University of Sao Paulo in Brazil. He's a researcher and specialist in sclerotherapy, laser technologies, and minimally invasive treatment of venous disease. So Marcos, thank you so much for being here. I've been following you for a while, and I admire what you do. So I'm very grateful that you're here with us and spending your morning with us. Go ahead and share your screen.
Oh, thank you, Nina. I mean, it's okay with my.
Yeah, we can see you perfectly. I think you just need to go on presenter mode, but we see your screen.
Okay. Okay.
Yeah. Perfect.
Perfect.
Yeah.
Well, today I'm going to talk about the use of sclerotherapy followed by laser. C1 disease is not a secondary cosmetic detail. It affects almost 40% of women over 50 years old. In some series, the number exceeds half of the population. Despite its slow morbidity, effective treatment improves quality of life, not just a cosmetic appearance. Sclerotherapy has been used for decades to treat venous disease with good results. In 2021, Cochrane published a systematic review pulling over 3,500 participants across 55 randomized clinical trials. In the results, sclerosing agents remain the most effective monotherapy for resolving or improving spider vents when compared with placebo. But the same review also found that sclerotherapy alone was associated with more adverse events and possibly more pain for the patients. So, if sclerotherapy is the most effective single treatment, why would we add anything else to this treatment? We have a multiple published article reporting the use of combination therapy. In here, the anatomic answer why we associate therapies. Not all the limbus veins are the same caliber, and some are simply difficult to close with sclerotherapy alone. This persistence of the vein network and favorite recanalization often requires multiple treatment sessions. If we treat the visible vein but leave the feeder vein untouched, we are treating the symptom, not the source, and the recurrence trend to follow. This gap is exactly where the second tool becomes relevant. And this is where combination therapy offers a clear advantage for the patient. In 2022, the AJVS had already reported the combining laser and sclerotherapy provides treatment benefits. This can take from a polydoconal sclerotherapy followed by laser, like Moreno Moraga described, or like Nara described recently, the laser followed by sclerotherapy with the CLaCS technique described by Dr. Miyake. The stronger evidence comes from a series of studies of Moreno Moraga and his colleagues published in 2023 and 2019 in Phlebology and Laser Medical Science. The main randomized trial compared two groups, 79 limbs treated with polydoconal foam alone versus 517 limbs treated with polydoconal foam immediately followed by laser. At 3 years of follow-up, the combination group showed clearance rates than foam alone. And it wasn't just clinical clearance. At 3 years, 19% of the patients treated with sclerotherapy alone remain satisfied and very satisfied. In the hybrid treatment group, the number was 86%. And why does it seem to work? Foam microbubbles inside the vasolumen increase the optical scattering. Picture the scenario. First, laser alone on a blood-filled vessel has low absorption and needs high energy to have an effect. If you put some scleros and combine it with laser, it produces a greater interaction at the vessel wall. But with foam sclerotherapy combined with laser, it increases a much higher optical path and transfer more energy directly to the vein wall. In 2024, we published our experience with this concept. In your case, we describe a cryo-laser after foam technique combining polydoconal foam sclerotherapy with laser using a cool air cooling. This was a patient with 3.9 millimeters reticular vein who achieved complete resolution after 4 months over two treatment sessions just with excellent aesthetic result in complication. No complications. This is the step-by-step approach we use. First, we map the venous network to identify the deep reticular feeder vein. Second, we inject 0.25 to 0.5% polydoconal, targeting this feeder vein to reduce hemodynamic pressure. And third, we apply the laser to the marked superficial venous network using a current cooling, cryo-cooling. Here we can see the patient results after just 2 visits, complete resolution of the reticular vein, the spider vein on the leg. In this case, a 90-year-old patient with varicose veins we treat the patient in 2 sections just, with follow-up 3 months. You can see a significant improvement both in the vessel and the skin tone of this patient. Here, using the same spot size and impulse duration, we treat a complex network of telangiectasias in a single treatment section. Follow-up was performed after just 30 days. Even one combination session, we already produce a meaningful early results. In this another case, we reduce a polydocanol concentration and lower the laser energy because the skin type of the patient. But after 30 days, we obtain these results. Okay, for the patient, it's amazing. And we can treat 2 malformations like this foot in a 21-year-old man that affecting his quality of life with edema and pain after physical activity. And this is a result after 3 months. In every case, we perform photosclerotherapy first, followed immediately by laser during the same treatment session. What we observe in our clinic is less pain for the patient when you use laser combined with skin cooling and polydocanol foam. And obviously, we use a lower energy setting, giving the patients less pain too. So I can summarize my approach with this image. We can combine laser plus sclerotherapy like a CLaCS technique. We combine sclerotherapy plus laser, liquid of one. We combine sclerotherapy plus radiofrequency. But we use to up for vents up to 2 millimeters. I use it sclerotherapy one plus laser, and for veins less than 2 millimeters, I prefer use the CLaCS technique. The take-home message is the combination probably beats monotherapy because sclerotherapy and laser act through complementary mechanisms to treat the same disease. Thank you very much, Lina, for the invitation. I'm sorry for my English.
No, it's perfect. No, that was absolutely amazing and perfect. So thank you so much. So let me ask you something. I see that you use even for reticular veins, larger veins, you're still keeping your polydocanol at less than 0.5%, right?
You're right.
Yeah, so I saw a few cases that you did 0.25, I saw some 0.5s in some cases. Do you ever, so obviously you're keeping that, really low concentration, again, assuming because you're going to have the second injury then from the laser, which is going to, help us achieve those results. Do you ever use glycerin or dextrose? Have you looked into that?
When I use for the CLaCS technique, no, just foam and plus laser. But I'm a fan of CLaCS technique, and I'm going to publish soon my new research about CLaCS and sclerotherapy alone with a solution, a weird solution with dextrose plus polydocanol. But when I want to treat these reticular veins with foam, I just use foam plus laser.
Okay. So same question that I asked for Nara, how's your specific approach on someone who has multiple areas on both lower extremities? Are you treating everything in one session? Are you kind of finishing working on one area, doing your foam first, laser second, before you jump to another area?
No, normally I plan 2 or 3 sections of treatment, and I try to treat all the patient every time she goes to the office.
Okay, perfect. Any other as far as like tips and tricks that you think are, you've changed over the years that make your results? I mean, you showed incredible results. Anything else that you do particularly that help you achieve those results?
I used to do compression in the reticular
That's a
vein.
great one. Yeah, for sure. I have that question for everyone. So
Yeah, just it. No other. I don't have another trick.
so you are having your patients use compression following the treatment?
Yes, but just for 24 hours.
Okay, perfect. Awesome. Okay, so I'm just checking the
We have
question.
a
So
question. Yes.
yeah, so I'm gonna ask. There's a few for Nara that we'll have at the end. But there is one from Dr. Boskert for foam followed by laser treatment for reticular veins. Do you ever do thrombectomies, or do you ever have to do thrombectomies?
No, when I do foam plus laser, the patient return to my office 15 days after. If I
Okay.
have a thrombus, I do the thrombectomy there. But with compression, what we see is the less thrombus.
Okay. Nara, are you there? Can you jump in as well? So I would like to know, since I asked Marcus this question, first, what's your protocol as far as compression post-procedure, and then same as far as microthrombectomy of any trapped coagulum post-procedure?
So, as I showed in the meta-analysis, there's almost any microthrombi to do drainage, because when we do the laser first, we do a lesion in the vein that the vein is how can I say, do a
Going
compression.
into spasm.
Yeah, spasm. Yes, thank you. So the vein do a spasm. So when we use the sclerosing agent after, we have less microthrombis, and I have microthrombis when I use pordoconol, but it's less when I use pordoconol first, then the laser, because I do this technique too, especially when I need less pain. A patient that is so painful, and so I use the foam first, but it will be more necessity of thrombectomy after.
Perfect. And then as far as compression,
I use class 2 socks only for to the comfort of the patient, because I use some cottons in the point that I did the punction of this sclero agent only, and I dress class 2 socks, only this.
okay, how long do you use them for?
Only one day. In the next day, the patient take off the socks and the cottons.
Okay, perfect. So there's more questions that come to my head, especially when talking about complications, which is, I think, the main thing that we want to prevent on our patients. So for that, I'm gonna give it back to Rebecca, who's going to introduce our next speaker.
Yeah, thank you, Lina. It's so nice to be here and to listen all these trips and tips. I'm gonna present Anelise Rodriguez. She's a vascular and endovascular surgeon. She's a scientific director for Brazilian Society of Angiology Regional MT, and a member of the AVF, an American Venous Forum International Committee, and is the owner and clinical director at Clinical Anelise Rodriguez in Brazil. Welcome, Anelise. Please share your screen.
Okay, do you get me?
Yes, perfect.
Okay, so good morning, everyone. It's a pleasure for me to be here and share a bit of my work with you. Thanks, Lina, for the kind invite. And let's talk about it. So I have no financial disclosures for this presentation. And the term post-sclerotherapy hyperpigmentation, or PSH, it refers to an abnormal skin deposit of either hemosiderin or melanin that happens after sclerotherapy. It's multifactorial, and the persistence of the microthrombi, the treatment of the veins that are located in the epiphyseal compartments, high blood levels of iron and/or ferritin, and also darker skin phototypes are some of the conditions that may be associated with it. Also, it's the most common adverse event after sclerotherapy. Some consider it even part of the procedure, but it lowers the patient's satisfaction and may actually be a reason for the patient to decline the treatment. So when patients come seeking for cosmetic improvement, it's a point of concern for both the patients and the physician. Published in JVSVL last year, our study compared two different treatments for reticular veins, focusing on the post-treatment hyperpigmentation rather than its efficacy. It was an open-label, prospective, and randomized active control with inpatient and safety trial, and it was conducted at a single center in Brazil. The aim of the study was to find out if CLaCS technique that was already presented today by Dr. Nara would cause less pigmentation when compared to 0.5 polyidrocanol foam sclerotherapy after a single treatment of the reticular veins. We treated 23 women and a total of 46 limbs. All patients had bilateral lesions, similar in terms of location and length and diameter. All patients sequentially received CLaCS for one limb and 0.5% polyidrocanol foam sclerotherapy for the contralateral limb. Which limb would receive which treatment was electronically randomized. One leading investigator was responsible for all the foam treatments, and the other one for all the CLaCS treatments, according to their expertise. After the first visit, where the treatments were performed, patients came back after 7 to 10 days for assessment and clot drainage, then after 30 days, and then with 60 days for final data assessment. 21 patients, meaning 42 limbs, completed the study and were analyzed for the final data. The primary outcome was assessed to before and after photo evaluation by three different blinded observers, all experienced in vein treatment. A picture with a white tracing was also sent for them to identify the treated areas. Each evaluator had access to only one limb per patient with no access to the other limb images. And they answered the question, do you think there is pigmentation on the treated area? Yes or no? The most frequent response was used for statistical analysis. And the co-primary outcome evaluation was through digital colorimetry. It compared the skin tone difference between the treated area and the skin in the adjacent area. The color difference is expressed as delta E, and although per definition a delta E over 1 is considered positive, a delta over 2 is considered clinically relevant since it's what can be spotted by an experienced observer. It's something that we can actually see with naked eyes. The second outcomes consider the intensity of pigmentation determined through colorimetry and expressed also as delta E values. Higher delta E means a more intense pigmentation. The volume of sclerosing used, the presence of microthrombi, and of course its drainage, pain intensity for each procedure using a visual analog scale, patient before and after aesthetic satisfaction for each limb using an aesthetic numeric analog scale, and the occurrence of minor and major adverse events. We found no difference in the number of limbs which presented pigmentation, neither for photo evaluation nor on objective evaluation with colorimetry. But what we found was a significant difference in the intensity of pigmentation, with foam showing more intense pigmentation than CLaCS, markedly for the patients with Fitzpatrick 3 and 4. And for patients with Fitzpatrick skin types 3 and 4, a delta E over 2 was present in 7 patients, being 2 bilateral and 5 only in the foam limb. So no clinically relevant pigmentation was found only for the CLaCS limb. There was also no difference in diameter reduction rates, pain scores, and number of vein punctures, but there was a significant difference in the volume of the sclerosant used, with a consistently lower volume for the CLaCS procedure. Also, there was less bruising and microthrombi formation, and consequently less need for drainage in the CLaCS group, with no difference in complication rates. And some food for thoughts now. So despite our primary outcome was pigmentation, I really believe that some of our secondary finds brought some important insight on other topics that are related for transdermal laser for vascular treatments. And considering our daily practices and certain scenarios, this point sometimes might be even more relevant than pigmentation rates itself. So first is the fact that despite we use fixed parameters, I use 70 joules per centimeter square with a 15 milliseconds pulse duration and a 6 millimeter beam for all patients up to Fitzpatrick 4, and a 50 joules per patients with Fitzpatrick 5. We got no skin burns, so it shows us that it can actually be used and safe on darker skins. And then the use of less volume of sclerosant may allow us to treat larger areas using the same amount of sclerosant, and then reducing the number of visits needed to finish a large treatment, especially when we talk about sclerosants with a safe max volume per session, such as polyrocanol, for example. And last but not least, the less microthrombi formation. It itself can lead and help to reduce pigmentation. But moreover, it translates into more comfort to our patients, since we all know that clot drainage can be bothersome and stressful for the patient. So in conclusion, this study, CLaCS showed a safer profile regarding pigmentation intensity after 6 days after a treatment, when compared to 0.5% polydocanol foam in treated reticular veins, using less volume of sclerosant and with less microthrombi formation, without losing its efficacy. It's a small study, but it brings up some data not only in pigmentation, but also on safety of the use of transdermal laser in darker skin. And for patients with cosmetic concerns and known to be more prone to pigmentation, CLaCS may be a safe and effective choice. So thank you so much for your attention. You feel free to contact me to email, direct message on Instagram. And for those who like the data and want to read a little bit more about it, the reference are on the QR code on the right. Thank you for your time.
Thank you so much, Anelise, for that wonderful presentation. While you're giving your presentation, there's a discussion sort of going on the chat, which I want to sort of bring over, because I think this is the main thing. I mean, I think that we all know that sclero works and laser works, but it's really, at the end, the goal is to try to not only get our patients to where we want them to be, but limit the complications. That is essentially what we want to avoid, especially in patients who are C1, and this is a completely cosmetic concern. And so, first, before I ask everyone else, I do want to ask you, what is your specific protocol preference? Are you a CLaCS? Are you a sclerophoral by laser? Do you use both? When would you choose one over the other? And then I'll have the same question for Marcus and for Nara.
Okay, so for most of the patients, I use CLaCS. I saw that, I think it was Dr. Kurshat, somebody asked me the diameter of the veins that I treated in the study. We treated veins up to 2.3 millimeters. So it is a little larger than what's described for the CLaCS technique in the beginning. But I think it was nice to just, with experience, to find out that this 1.5 was okay, but we can do it up to larger veins also. In my clinic, normally I'd start with CLaCS for the majority of the patients. When I have larger veins, I actually use foam plus sclerotherapy. Also, is something that I've incorporated in my clinic. I tend not to use foam alone. I basically use laser for the majority of my patients, either with sclerotherapy, with liquid sclerotherapy, or with foam. I use sometimes liquid polyrocanol, but only for patients who have very persistent lesions that doesn't respond to dextrosis, like up to 2 mm veins that we try with CLaCS with dextrosis and it doesn't respond. I try then to use the liquid polyrocanol, and there's a less resource foam for those patients. I saw that you had like this main doubt about the extent of the treatment. So do you do like per session or not? The point is when you're doing CLaCS, for example, you start with laser, you get the spasm of the vein. So if you do the laser in the entire leg, when you go down there to try to put the sclerosis, it doesn't go through. So you had to do like spot by spot. And when you have like a giant cluster, and you have multiple feeder veins in the same cluster, I tend to not treat all of the feeders at the same time because it facilitates the occurrence of matting. So try to find out which one is going to the lesion and treat the reticular that's going towards the lesion and find the escaping vein. So if it's like an outflow vein, try not to treat it in the first place, like in the first moment, because you're probably gonna get some matting for this. And also
Yeah,
for the foam, I do the same, like you treat step by step, because it's different when you do the foam first. The action is different. You have the laser after the foam, you have a scattering of the energy and also the analgesic part. So you need the foam to be inside of the vein for you to use the laser for it to be more effective. So if you do everything and then you come with the laser, you lose efficacy. So it's like a waste of resources, I mean. Right?
Yeah, I think it's important to go over those little details because we tend to, when we have these discussions, and I've had them with several people or, in different meetings, it's like, it's not just what goes first and what goes second, like literally getting down to those like nitty-gritty details is so important because it makes a world of difference. Like you're saying, I mean, it's very important if you're using laser, like you just said, following foam, you need to have the foam to get the benefit of the increased scatter and all of that. So that's why I want you guys to really get down to like the very little detail as far as like how you guys do it in your own practice to get the results that you're achieving. So so let's, I want to go back to Marcus because I know Dr. Kapnick in the chat had that same question for you. So you kind of had a slide there talking about the sizes. So why don't you go ahead and tell us a little bit more about that again? Like when you go with one versus the other.
Yes, to answer the question, I usually use to veins up to 2.0 millimeters. I use CLaCS technique. And when I treat the veins above 2 millimeters, I use the CLaCS technique. Because we have paper published treating veins with CLaCS technique above up to 2 millimeters. And the Dr. Miak says that the technique was described for 1.5. You can use up to 2.5, but for veins bigger than this, we don't have a literature to show
Support
us supporting us. Sometimes I treat 2.5, 2.2, 2.3, but what I see is not the result in just one section. I have to do more sections for this patient.
Understood. And then, Nara, I know you were mentioning the discomfort part, and that may play a role into how you particularly choose which method to go with or sequence to use. So would you mind elaborating that a little bit more?
Well, I prefer do CLaCS technique. I do the laser first because this makes the more absorption of the laser by the chromophore that is methemoglobin, and this do less sclerothrombi, and I do I use the CLaCS what you asked, the 20-30 millimeter of is the CLaCS, or you asking, Lina? I forgot.
No, because it's just Dr. Kapnick and in the chat, we were wondering like why, Why go
Yeah.
with one or the other? And obviously you guys have said that or some of you that you use
Yes.
both, and so like we want to understand what your rationale is with going with one versus the other. Marcus had said that it's about size. I think you had mentioned something about discomfort, and so that's kind of what we want to clarify, so that
Yes, I use the sacs only for the comfort of the patient, because the sacs makes analgesia. When we put the sacs in the patient, and most of the time you don't need to use like analgesics after the procedure. The dextrosis cause pain. And after the procedure cause a pain. And when we put the sacs, the pain is gone. So I see this in my practice, and I started to use the sacs because of this, for the comfort of the patient and for the edema too. When we treat many veins, almost the time we do a little of edema, and the sacs do this, treat this, but it's not for the compression of the vein, because when we use laser, we don't need this kind of compression.
Lina, also what I see here, and probably you're gonna see with your own patients there, I live in a very, very hot place. You do, Nara does as well. And what I found out, and I mean, it's not in papers, but I tried it myself. I did like my self-study. I treated my both legs. And what I see in my patients is when we put the stockings right away, they tend to get less bruising when they start moving after the treatment. So the patients have bruising for less time. And for patients who are worried about putting their legs outside and everything, it does make a difference. I mean, it doesn't make a difference in the overall outcome of the treatment. In the end, after 30 or 60 days, they are pretty much the same. But after 1 week, the amount of bruising that you get in a patient that has used the stockings and those who doesn't, believe me, it's really different. It makes a difference. And apart from the comfort and all the other things that Dr. Nara have already said, it's something that I noticed. And for this kind of patient, it's important too.
that's so good to know. Yeah. I think Rebecca,
Yes.
were you gonna ask?
Yes, and I want to ask about the aftercare. What do you say to your patients? How do they have to take care of the legs? If they can take any medication after the treatment, if they are allowed to do some exercise or not. Of course, we know that the sun is prohibited because of the hyperpigmentation and everything. But what do you say to each patient when they go out? Do you give up a paper to the aftercare? I don't know. I want to ask that.
Yes, I do I do a paper, and I wrote in this paper to use to get off the sacs in the next day, to use a cream with alpha bisabolol. There is a kind of clarificant of the skin, and if hydratant too, to hydrate the skin. And sometimes I do medications, but almost the time is not necessary. Only when the patient has symptoms. When the patient is very symptomatic, I do analgesic. Here in Brazil, we use dipirona so much, but
Okay, thank you. And Dr. Fonseca, please.
I don't have no restriction before the treatment, after the treatment. Before, I ask for the patient don't take sun. So for how can I say, sorry, I ask him to don't take sun for 10 days before the treatment, cause the pigmentation that we can see after the treatment. But after the session, she can go to the gym, she can walk, and she can do what we can.
Okay,
So you
and
don't
the
care about
after-
sun. Oops, sorry. You don't care about sun exposure afterwards.
No.
Okay.
I live in the south of Brazil. It's a little bit less sun than the north.
And whiter people, like
Yeah.
people
Oh, so
in the
you're
south of Brazil are
lucky.
kind of
Yeah.
white. They can
Or if
do
it's
We're
pretty much
screwed.
everything. They don't get pigmentation. It's different from like this melanin people, the
Yeah.
mixed skin that we have like in the north and northeast of Brazil. So my
Yeah.
patients are not, I tell them not to go in the sun and while they have bruisings or any kind of, you know,
And I live in
sign,
the beach.
something that could get a stain on them.
Listen, we have 5 minutes left, and I do want to touch about something that we barely mentioned, which is matting. So in one split second, are you guys seeing matting? We know that the incidence is about, I don't know, 20%, 30% after regular sclero. Just really briefly go, Anelise, what's your...
For the patients we have one matting, and it was for the foam limb. And I don't get that many mattings unless I'm treating very, very extensive lesions. And when I try to do everything all at once, sometimes I can get it and it's very transient, but I don't get matting with laser and sclerotherapy. I lied.
Okay. Marcos?
Yes. With laser and fun and laser, I have some mattings, but it is after 2 or 3 months, it's
Resolved.
I'm sorry, resolve.
I don't have any so much matching. I use the augmented reality to see the feeder veins to avoid the hemodynamic matting, and I use more dextrosis, so as a mild agent, esclerosant agent. So, and I think this causes less matting. I think it's like this because of this.
Perfect. Well, listen, it's 9:57. I wish we had more time to keep discussing. I put my email for all of the attendees. There's my email is there. Please, please make sure you copy it really quickly. Send any questions that you have for any of the speakers, and I promise that I will forward it to them and get back to you with answers. I wish we had more time. But I want to thank you all, the speakers, the people who just took some time to be here with us. This is very important. We want to continue growing these Empower series. They happen once a month. And I want to invite you for the future one in August. We'll be sharing it. It will be about perforators. So a very, very important treatment and how we address perforators around the world. So that is going to be a very important topic. So thank you so much for being here. Stay in touch through our social medias. We'll make sure to post this link. I know there's so many people who wanted to be here, interested in this very, very important topic. Thank you so much.
Thank you, Lina.
Thank you.
Thank you.
So
Thank you,
nice.
Rebecca.
Oh, thank you, Lina.
And thank you, Victor, for
That
making
you
all of
can
this
see.
happen, and VLU executive